Okay, it's 10 o'clock. So, hello, everybody, and welcome to today's webinar. In order to begin, I'd like to acknowledge the traditional custodians of the lands and waterways throughout Australia and pay my respect to elders past, present, and emerging. I also extend that to any Aboriginal and Torres Strait Islander guests who might be joining us from around the country today. I'm coming to you from Meanjin or Brisbane on the lands of the Turrbal and Yagara peoples. I'd also like to acknowledge the ongoing impact of colonisations that our First Nation Australians, including the disproportionate impact of substance use on their health and well-being. My name is Ben. I'm an educator here at Insight, and it's my pleasure to be introducing our presenter today, Dr. Krista Siefried, who's going to be talking to us about digital health and methamphetamine. Krista is a very busy woman. She leads clinical research and clinical trials in populations at risk of harms due to substance use disorders. She's the clinical research lead and deputy director at NCCRED, or the National Centre for Clinical Research on Emerging Drugs, and a senior lecturer at NDARC, or the National Drug and Alcohol Research Centre, and within the Alcohol and Drug Service at St Vincent's Hospital in Sydney. Throughout the webinar today, we really love to hear from you. So please do provide to us your comments and questions in the chat. I'll keep a note of these, and at the end, when there's time for questions, I'll ask as many as I can on your behalf at the end of the presentation. Just so you know, you won't be able to see other people's comments in the chat, but please do rest assured that they all do come through to us and I'll be compiling them. If you're looking for the slides for today, they're going to be packaged up at the end of the webinar and will be available to download from the Insight website on the page for this webinar, and they'll be there as a link. We're not able to provide them in the chat today, but they will be available to you soon. So thank you for listening to me, and over to you, Krista.
Thank you. Thanks so much, Ben. Thank you for having me, and thanks to Insight for hosting this series. I'm always interested by the diversity of talks and information that we can get through this series, so appreciate being invited. I will start by just echoing the acknowledgement that you made of acknowledging that the research that I'm presenting today takes place on Indigenous lands across Australia. And I do recognize the strength and resilience of those people who maintain a continuing connection to the lands and waters in all of those regions, a right and responsibility that was never ceded. And I acknowledge any traditional owners and caretakers of the nations throughout Australia who might be present today. So just a couple of housekeeping items. The studies that I'm presenting on today, the SCHECK study and the IMPACT study, are funded by the National Centre for Clinical Research on Emerging Drugs, that's NCCRED, and NCCRED is funded by the Australian Department of Health and Aged Care. I don't have any commercial interests to declare outside of my employment at UNSW and St Vincent's Hospital, Sydney. I do receive research funding from the Department of Health and Aged Care and the National Health and Medical Research Council of Australia. I'm hoping that this presentation will outline the current data on methamphetamine use and treatment in Australia and overview the evidence-based psychosocial therapies that underpin treatment in Australia and digital health interventions to be discussed. And I'm hoping that I can provide an overview of digital health interventions in the Australian context. I've just seen a comment come up that my sound might be a bit tricky. If anyone can just promote that comment or echo that comment or confirm if you can hear me.
I can hear you quite well, Krista. So I'll send a chat to Melissa, but
Perfect.
You're coming through loud and clear on my speaker.
Thank you. I'm hoping, Melissa, that it's a one-off situation, but we'll see how we go in a moment here.
Sounds good.
I'm hoping that following the presentation, people who have attended today will have a deeper understanding of the digital health interventions for methamphetamine use and have gained some insight into how they can be implemented, as well as what the sector may be wary of. So as a bit of a background, the prevalence of methamphetamine use and methamphetamine use disorder or dependent use is globally estimated to affect about 96 people per 100,000 population, which equates to about 7.4 million people. These data are difficult to ascertain, so there is a confidence window there of about 70 to 128 people per 100,000. And the highest rates of dependent use have been identified in Australia and North America. A bit of background for treatment in Australia. So according to the AIHW data up till 2023-2024, treatment where methamphetamine was the principal drug of concern, treatment episodes that were closed in that that financial year were nearly 60,000. So as you can see in this graph, there was a little bit of a downward trend around the COVID-19 period, 2019-2020. But that has continued to rise in the years following. This really is indicative of the treatment-seeking population and the fact that people are seeking support for methamphetamine use. And just as an overview or a review probably of non-pharmacological treatment for methamphetamine use disorder or methamphetamine dependence, the standard of care involves psychosocial therapy to assist in reducing use. These have demonstrated modest effect, but the effect is often not sustained following cessation of the treatment. So this is kind of our treatment as usual or standard of care option in Australia, particularly for methamphetamines where we don't have a pharmacological option. There are no licensed medications to support people with reducing or ceasing their methamphetamine use. Cognitive behavioral therapy is one of the mainstays, CBT. This is based on the understanding that behavioral patterns and cognitive processes around drug use are learned and can be modified, that patients are introduced to new coping skills and cognitive strategies to replace maladaptive behavior or thinking patterns. It's structured, and CBT includes specific goals. It's focused on immediate problems faced by the patient in the present. There's also motivational interviewing, which I'm sure a lot of people use in their daily practice who are on this call. The aim of motivational interviewing is to increase the participant's own motivation to change a behavior. It's very collaborative and recognizes the autonomy of the patient. The clinician is an advisor. It's not an authoritative approach. And the clinician really seeks to understand patient values. The patient may come to realize that substance use is not aligned with the things that matter to them or what they want to achieve. This can also support reducing high-risk behavior, for example, in the context of methamphetamine use, perhaps unprotected sex or needle sharing. And finally, I'd like to end on contingency management, which has gained a lot of traction and a lot of discussion at the moment. It's recently being implemented in DVA sites in the US, but there really hasn't been wide clinical uptake elsewhere, despite evidence based to suggest that contingency management is one of our strongest psychosocial motivating therapies to change. So contingency management refers to the provision of rewards or money for achieving goals. Usually this is around verifiable abstinence. The rewards tend to begin at a low value and increase as the number of sequential goals are achieved. This can be controversial. For example, what goals are we rewarding? Is it limited to abstinence? Is it open to incorporating other goals that might be more patient-centered or more patient-orientated? It has been criticized for cost, although I think that there's probably a very good argument to suggest that other modalities are even more cost-intensive. There is, of course, criticisms that it fails to address the social determinants of health. There's parallels to gambling if it's prize-based or draw, like a prize-based draw at the end of an achievement. And there are general issues about the role of healthcare providers in the context of contingency management or the justice surrounding payments. So where does digital health have a role in and amongst all of this? So digital health interventions, or for the rest of the presentation, I'll refer to DHIs, offer a potential in the AOD space. So they're portable. You can access where you are, when you need or want to. They're cost-effective access to evidence-based information. They circumvent wait lists, and they can support a stepped care approach. For example, implementation of a DHI whilst someone is on a wait list for a face-to-face intervention. DHIs have unique considerations, so we need to worry about where the data is stored, under what legislation the privacy is protected. So for example, who would have access to that data? in terms of a breach, for example, hacking, or in terms of litigious contexts. For example, would it be able to be subpoenaed and used for litigious purposes? How is the data stored? Is it de-identified? Is it re-identifiable? Can it be linked to a person, or is it completely anonymous? These are all questions that really need to be taken into context when implementing a DHI. And then there's, what is the evidence base for intervention? So who stands to benefit from the intervention? For example, when you go onto the App Store and plug methamphetamine in, do you see a lot of apps that might have commercial interests, commercial gains? Have they actually been designed with the participants in mind, or with the end user's goals or wants or desires from a smartphone application, as an example? So in a scoping review of literature, we found several studies examining DHIs in the context of methamphetamine use. Now, this is data that my colleague Kat Fletcher has been putting together and is currently under review. However, I can tell you that when we went to the literature and looked to see what kind of digital health interventions are being assessed in a research or evidence-based or rigorous way, we certainly found that studies are very heterogeneous. So for example, they're heterogeneous in their target populations, whether they're targeting methamphetamine use or methamphetamine dependence. And sometimes, unfortunately, it's not entirely clear. They're heterogeneous in their approach. So for example, their modality. Are they web-based, text messaging, smartphone apps? We found chatbots and virtual agents, as well as virtual reality in their underpinning theory. Most often we found that they are wrapped around CBT, or cognitive behavioral therapy, or motivational interviewing, which we just reviewed both of those models. And the methods of assessment. So when somebody publishes research on a DHI, what are they actually researching? How are they gaining the evidence? How rigorous is it? We did find some randomized controlled trials. We did find some cohorts, so sort of reporting on the people who took up the app. Obviously, both of those have limitations and certainly biases around who has access, how they're accessing, how they're finding out about it, a variety of limitations that need to be considered when we're sort of evaluating whether a DHI is useful or not. And then they were also heterogeneous in their measurement of outcomes. So were they looking at methamphetamine use? Were they looking at craving, intervention satisfaction, so satisfaction with the app or modality or DHI itself, acceptability of the intervention, help seeking, cognitive function? We found a broad range of ways that researchers who implemented DHIs went on to evaluate whether they were a good DHI, as it were, or not. And then also recognizing the limitations within the literature around the fact that not everyone who creates, implements, or releases a DHI on a platform, for example, on your Android or iOS app stores, has actually gone through and done any of this process underpinning their outcomes. So oftentimes these DHIs are out in the wild without any research or any publishable track of where they have come to say that they are a useful intervention. So where do we sit in the Australian context? What have we been doing in Australia to implement these technologies or to create these interventions for the context? One of the sort of longest standing digital health interventions that I can think of in Australia is certainly Cracks in the Ice. So Cracks in the Ice offers targeted information and resources for people who use methamphetamine, or crystal methamphetamine in particular, colloquially known as ice, for community members, family, friends, health workers, schools, or early intervention points, as well as a toolkit that's tailored for First Nations in Australia. So these resources have been tested and assessed for the change on knowledge and attitudes after exposure to Cracks in the Ice. And following, so in 2018-19, Cracks in the Ice was evaluated by surveying, so I've gone two ahead, sorry. I'm just gonna go back one. A bit of a time lag in my slide change, sorry. So after being exposed to Cracks in the Ice as a platform, there was a decrease in participants' negative or stigmatizing attitudes towards methamphetamine. And so really there is a potential here for Cracks in the Ice to reduce stigmatizing attitudes about methamphetamine, as well as experiences of discrimination in Australian people who come into contact with people who use methamphetamine, or families, friends, etc. Cracks in the Ice really does have the potential to reduce those stigmatizing attitudes. And here are a couple papers that support that in terms of cracks in the ice. You can scan either of these QR codes to read both the evaluation as well as a cross-sectional study. Oh, I've gone too fast against the slides here. And now another intervention introduced by Cracks in the Ice is Breaking the Ice, a free online intervention based in CBT to support young people who are using or thinking about using crystal methamphetamine. And so for more information, you can visit or download the apps on the Cracks in the Ice websites. There's an info email address there. You'll get the slides. The slide deck will be available by PDF following this presentation. And herein we have the next resource I'd like to talk about, which is the What I Want-T, or We Can Do This, Leave the Ice Alone web app. So this was implemented in Australia, targeted especially for Aboriginal and Torres Strait Islander people who use methamphetamine. And this was evaluated by a web-based application. This was evaluated as a web-based application. And the developers of this app went on to establish a randomized waitlist controlled trial in which they found people who were randomized to the app immediately or people who were randomized to a waitlist and then had access to the app several days later didn't have statistically significant differences in their methamphetamine use and other outcomes associated with methamphetamine. However, I think, and the paper that describes that is available there by that QR code. However, I think that there are contexts where this app has left quite a impression in terms of how it might be used outside of this kind of clinical trial interface of a randomized waitlist controlled trial. And so to demonstrate that, I'd like to just share a video here. Hopefully this is going to work. Let's see if we can.
What I Want-T, translated in English, means leave the ice alone, and is the title for this evidence-based therapeutic web app that was developed to assist Aboriginal and Torres Strait Islander people to stop or reduce their use of ice. It also supports harm minimisation when using and helps to overcome barriers like stigma when accessing the health services. Starting in 2016, researchers from the South Australian Health and Medical Research Institute, SAMRI, and the University of Queensland worked with the Port Lincoln Aboriginal Health Service and West Coast Youth and Community Support on Neo Bungala country, along with other First Nations people around Australia, to help develop the web app based on quantitative and qualitative research, with around 1,000 participants nationally. My name is Jason Ramp. I'm a First Nations filmmaker and a Neo man who works at the Healing Circle in Port Lincoln, South Australia. With the assistance of an NCCRED scholarship, I have shot documentary-style interviews with both clients and lived experience workers over the period of a year, to help better understand how What I Want-T might be used in a real-world context. Also to see how What I Want-T fits into the context of a health service that is busily responding to a range of diverse, different needs.
The good thing about having someone with lived experience that has looked at the app and can go through it with a client can actually pause it if the client looks uncertain what that meant or didn't understand something about the app. You can pause it and you can actually sit there because you know yourself that you can answer the questions that they're going to ask you.
Overall, participants in the research describe using methamphetamine recreationally first, but it soon escalated to become a problem for them, often caused by complex and traumatic life events.
Once you've shot up, you're not going to go and swallow it compared to shooting up, you know what I mean? It's just, once you've had that first rush and that feeling, you're just constantly trying to chase that. There's a lot more to it than that. There's an actual underlying fact for why I used to take drugs. That was just to try and cover things that happened to me when I was younger. Because I still haven't dealt with a lot of things. Drugs was my way of dealing with them.
The web app was found to be a useful tool for counselling and something that could fill in some of the gaps in current services.
Using the We Can Do It app with Kenny was pretty good because I'd already used it, so it was good to be able to sit and watch somebody do it, and if they had any trouble they could ask me what to do, and working through it with somebody else was good too, because I could see how they dealt with it as it come up, you know, if it was straightforward for them.
I just need to test my microphone. Can you still hear me after sharing that?
Yes, we can still hear you. Thank you.
Great. So I think that video really highlights how perhaps there are different uses for some of these DHIs outside of participants being asked to sign on to a clinical trial on a waitlist controlled RCT and then use the app in that autonomous way. I think that this video really highlighted where there can be peer support or clinician interface around the use of a DHI. And so on that note, it segues into a couple of the NCCRED resources that are currently available or about to be launched in the DHI space. So the first one that I'd like to describe is the SCheck app. So the SCheck app was originally based around a model of care that was implemented at the STP at St. Vincent's Hospital in Sydney. It was stimulant-specific brief intervention aiming to enhance engagement and foster harm reduction. It built on data from Smout et al., including a 4-session model of biopsychosocial assessment and feedback, physical health assessment and feedback, goal setting, and care planning. So similar to the Wadawanti app and the Breaking the Ice study, we ran a randomized controlled trial whereby people were randomized either to immediate access of the app or a 28-day waitlist, so whereby they got full access to the app after 28 days of waiting. And it was of people who use methamphetamine at least once in the month leading up to the intervention, the download of the app. So the study has been published, and that QR code should link across to that publication. The primary outcomes were actual help seeking, intention to seek help, and readiness to change. So this particular intervention wasn't based around CBT. It was an earlier intervention based around accessing support or help or identifying the difficulties that might exist around your relationship with methamphetamine. So really for people who are curious about their methamphetamine or starting to explore whether methamphetamine use has become problematic in their life. Participants in the immediate access group in our study were more likely to seek professional help at day 28. And while we had no significant difference in the odds of intention to seek help or actual readiness to change, a secondary analysis did demonstrate significant difference in odds of professional help seeking for participants who weren't seeking help at baseline. So interaction with the app was more likely to influence responses to help seeking throughout its use. So what we found was that every minute in the app increased the likelihood of seeking help at day 28 by about 8%. So we took those results and qualitative feedback of participants who participated in that study to launch SCheck 2.0. So this next version of the app is very much similar to the initial version, whereby it includes such models as self-assessments, where app users can complete 7 self-assessments that cover different aspects of their health, things that might be affected by methamphetamine use, so psychosocial well-being, social health, lifestyle, physical well-being, sexual health, thinking and thought patterns, and methamphetamine use. The self-assessments are composed of 1 to 5 questionnaires. Those are derived from clinically valid measures or from the SCheck model of care. And after each layer, the app user receives targeted feedback and also signposts for suggestions. So this is very deeply embedded in MI, EMA, so ecological momentary assessment and feedback. The next part of the app is really about tracking a participant's mood, tracking a participant's methamphetamine use, tracking things that might be affected by methamphetamine use, such as sleep. So really kind of diaries and logs. And then there's resources and signposting. So link outs to services or information based on your questionnaire, your individualized questionnaire results, and automatically generated PDF letters for GPs based on the results of selected questionnaires. So if we're worried based on results. And another little video that ought to work here.
SCheck is a mobile app for people who use methamphetamine to track and understand the impact of their use. Developed by the Stimulant Treatment Program at St Vincent's Hospital, the app has been clinically trialled and uses clinical assessments and questionnaires. The app has 3 main features. SCheck helps people to track their use, mood, and sleep each day to better understand the impact of methamphetamine on their well-being. The tracking feature shows average monthly scores for sleep and mood, along with cumulative use each month. In the app, people can complete questionnaires on different domains of health that may be affected by methamphetamine, receiving targeted feedback based on their answers. There are self-assessments covering methamphetamine use, physical health, psychological health, social well-being, and sexual health. Each self-assessment contains a number of questionnaires derived from validated measures and the SCheck model of care. After each questionnaire, the app provides information and resources about their answers based on their score. App users can access trustworthy resources and services for additional information and support with specific issues. The resources linked in the app have been evaluated based on their credibility, accessibility, and relevance. For selected questionnaires, app users can also download pre-populated letters to share with their GP if their score indicates a particular concern. The SCheck app is being evaluated as part of a research project, meaning that app users have to sign up as participants for the research. As a result, the app is only available to people over 18 who are living in Australia and have used methamphetamine in the last 28 days. Eligible participants can download the app now via the iOS or Android app stores. For more information, visit scheckapp.org.au.
So that app, the SCheck app, is available now, and it's free to download in Australia from app stores, as described by my colleague Dora in that video. So really, again, this is being run as a research project at the moment, which has legislative frameworks in place for protection of privacy, for example, and that app collects data anonymously. If you have a client that you think would benefit from that app, or you'd like to try it with the client, then I would encourage that to be downloaded from those app stores. And then the second resource that NCCRED is currently implementing and pretty soon ready to launch is the Impact Internet CBT program for methamphetamine. So CBT for methamphetamine, so similar to breaking the ice or Wadawanti, similar to other studies that have been done around interventions, digital health interventions in other substances. Electronic internet or mobile health is a new wave in health service design. So this potential, particularly targeted for people who use methamphetamine. CBT is didactic, so there's teachable skills and suitable for self-management. So again, this low threshold intervention that can happen with evidence-based resources that doesn't necessarily require clinician-facing or interaction, although I think that there are some questions following Jason's video that we watched earlier around how these tools could be implemented in that setting as well. There have been mixed efficacy results for these DHIs for substance use disorders more generally. And as we mentioned, we've overviewed the examples that we have for methamphetamine. There's a lot of heterogeneity in those studies. The studies often don't involve a control, or if they are a control, they're a waitlist control, which I think is probably the best method for such an intervention. There is, of course, researcher bias. So, for example, we talked about earlier who has consumer interest or conflict when it comes to some of these interventions. So engagement with mHealth applications is generally low for stimulant use apps. However, I would sort of contextualize that with the fact that mobile health interventions have a very low retention rate overall. So that's just something to hold in mind when we're evaluating these resources. Again, as with most of the psychosocial therapies that we have in our toolkit, there are modest effects of the intervention. Often these are non-statistically significant in terms of the results. We saw that with breaking the ice. We saw that with Water1T. So here what we've done is we've really considered heavily the design and tailoring it for people who use methamphetamine. And then we also want to explore the blended care approach. So what I suggested earlier with Jason's example of whether having a peer-led or clinician-led experience might influence how these interventions are taken up and used, and what their sort of effectiveness or reach is. Translating CBT into an online program for methamphetamine, this impact study was really implemented with a lot of source material that was established by other internet CBT programs, for example, for anxiety, postnatal depression, or other interventions that is delivered through This Way Up, which is a publicly available resource that's typically clinician guided or clinician prescribed, as it were. But then we took a really methamphetamine specific approach. So a brief cognitive behavioral intervention for regular amphetamine users, a treatment guide developed in 2003, as well as counseling guidelines from a number of resources. I've just pulled out a couple there. We had heavy consumer engagement on this resource. So we had 4 consumer focus groups as well as consumer resource review. So all of the resources that are included in the program have been reviewed by consumers at every step of the way and basically approved by consumers prior to releasing this intervention in a couple months' time. We have a clinical reference group that's multidisciplinary. They've met with 8 steering committee meetings in 2023 and 6 review meetings in 2024. So that has a multidisciplinary approach. You have psychiatry, psychology, registered nursing, academia, peer workers, Aboriginal health workers. That team is composed of a variety of folks across the multidisciplinary field in AOD. And then design considerations. We really took into account user experience, tailoring CBT, particularly to methamphetamine use disorder, simplifying jargon and terminology, overviewing design approaches and learning how to implement these in a way that's accessible and adapted in the appropriate ways. There's clinical governance, risk management, and digital frameworks that underpin its release in a short time. Aiming for in the next couple of months. So the program is web-based. This is not an app, similar to SCHECK being an app. This one is actually web-based. It's modular. There's 5 lessons and 1 bonus. It's self-paced, although the program recommends a weekly engagement. There are over 30 CBT-based activities and worksheets, as well as 5 homework practices or sessions. There are 10 character videos and 5 instructional or informational videos. So just to give an idea of what that looks like. And I'll play this lovely video from Dora.
Impact is a new, free, 6-week online program designed to help people change their relationship with methamphetamine. It's private, self-paced, and grounded in proven techniques from cognitive behavioral therapy, or CBT. Each week, you'll unlock a new lesson where you'll watch videos and complete science-backed exercises. You'll learn strategies to understand your methamphetamine use, work with cravings, cope with stress, and improve your well-being to help you make a change. We're running a research study to see how helpful and user-friendly the program is. If you're over 18, living in Australia, and have used methamphetamine recently, you might be eligible to take part. In the research, we will ask you to complete surveys before, during, and after completing the Impact program. If you're ready to make a change and want to try something new, Impact is ready for you at your own place, in your own time. Learn more or sign up at our website.
I just want to finish with a couple of discussion points. DHIs are an emerging resource for methamphetamine use. Early interventions for methamphetamine use disorder or methamphetamine dependence are required. And we know that options are required that can be accessed anywhere, including rural or remote, and also at any time. So when and where a person needs the intervention or is looking for the intervention. The potential use of DHIs while on waiting lists for face-to-face services, I think, is an area that we haven't explored enough. As well as the potential of DHIs under clinical supervision. And this could really be an important resource to access evidence-based interventions alongside or in support of a diverse AOD workforce. So for example, we could have peer workers who incorporate and step through and guide people through these the uptake of these resources. So really it could be a two-way conversation starter. It could be a stepped care approach and a wait list. It could be something that's used with guidance or independently. I think that there's still a lot of areas that we haven't explored with these interventions. There are also a lot of considerations that we need to carefully think through and be aware of when we're implementing, incorporating, or discussing DHIs in this context. For one, DHIs are often published with limited to no evidence base in support of their intended outcomes, so no research really underpinning their results. We have to be wary of economic interests or conflicts when we're referring a client to a resource such as a DHI that's been developed with a really underlying economic gain for someone else, as opposed to a consumer-focused and consumer-based intervention. Top-down approach, they really need to be informed by consumers, not by a group of folks who are developing an app because they think it'll work or they think it's needed. It really needs to be informed by the people who will be accessing, using, and hopefully benefiting from these resources. I think we need a greater clarity of outcome and aims. So for example, being really clear whether the app is aimed at someone who has methamphetamine dependence or aimed at someone who has methamphetamine use. Whether it's aiming to reduce use, achieve abstinence, or to promote healthy lifestyle, etc. It's not always clear when you're looking at the resources that are available. And also something that I haven't touched a lot on in this presentation, and another project that we're running at NCCRED at the moment, is really where AI interfaces with all of these conversations. And AI is a very fast evolving space, and it really felt out of scope for today's presentation. But if I'm lucky, Insight might have me back to present some of these results that we've discussed today for those trials, as well as the ongoing AI studies that we're working on at NCCRED. And now I really wanted to open it up for questions. And I think I've seen some coming through, but I think I'll let Ben pop back in.
Thank you so much, Krista. And we would absolutely love to have you back. So please, yes, that would be excellent. We'd love to hear more. We have a couple here. Welcome, thank you. And I'll kind of sort them as I can. First one is, in terms of accessing these apps, you mentioned that they're kind of searchable on the iOS App Store and the Google Play Store. Is there like a link or a particular way that's best for maybe clinicians if they'd like to suggest that their clients have a look at these apps? How might they do that?
Yeah, so I would recommend the NCCRED website, so ncred.org.au. So there are direct link outs to SCHECK at the moment, and we're launching the video that I just shared now so that clinicians can have a sneak peek, because one of the limitations, of course, is when you download the app, if you're a clinician who's curious, and of course you want to be able to verify what you're sharing with your client. What we found was that, of course, we released it as a research project. And so we didn't want people, curious onlookers, or people who wanted to figure out how it worked. And of course, we've had clinicians reach out and say, well, I don't want to skew your data, but I really need to know what's going on here before I recommend it. And so we've released some of those resources, including the video that I showed earlier, onto our website. And also getting onto the NCCRED mailing list in support of being aware of new resources. So for example, when Impact is launched, we'll be sure to let that be known to our mail out. So please do join the mailing list as well. I promise we don't spam. We don't spend too much time with unnecessary emails. We try and limit it to outputs and resources.
Perfect. Thank you, Krista. So by the sounds of it, for anyone looking to get more information about that app, the best thing to do would be to Google NCCRED, NCCRED, and then that will take you to the website. Another question. So there's kind of two here that are related. So I guess I'll read out both
Yep.
and let you in whatever way you feel is best. So question A would be, what do you see as the greatest opportunities and conversely the greatest limitations in using digital health to support people who use methamphetamine? And then related question would be, what do you see as some of the strengths and weaknesses of app-based treatment provision, especially in populations of people who have difficulties with substance use?
So I guess some of the strengths and sort of benefits, greatest assets. So I guess the biggest thing is really being available when and where people need support. So being able to have a resource at 2 a.m. in a regional setting, for example, where those things don't always exist. And I don't discount the fact that we still have the ATIS information hotline available 24/7. There are lots of resources out there, but I think that this is just another way of creating what one of my colleagues used to refer to as like a basket of resources that we can offer people to dip into and out of at their own pace in a way that suits them at their time. Substance use is a continuum. It's not sort of defined by being one way or one type of use at all times. So people may require something like the SCheck app to monitor their use and be curious and look for support or advice. And then there might come a time when that transitions into needing something like impact, whereby they actually feel like they need to change some behaviors around their use as opposed to tracking it. Similarly, there may be a need for an Indigenous, culturally sensitive and culturally specific resource, which Wadawanti can deliver. And so there's sort of a basket of resources that we need to be aware of and sharing with our clients, particularly when the resources are free and accessible in this way. And then the next part of the question was where I see it going or what might be a limitation. So where I see it going, I think it's really important to reflect, particularly with Jason's video, around sort of how we haven't implemented these as like a clinician, not supervised, but clinician guided or consumer guided or peer worker guided resource. So sort of looking at that a little bit more rather than most of our studies are around these waitlist controlled trials where we put it out in the wild and see who picks it up. Half of them go onto a wait list, half of them don't, and then we look at their outcomes later. I think that's very different to sitting with someone and going through the questions and having those thought-provoking moments with someone else in that sort of like evidence-based framework, but with the flexibility of the sort of peer or consumer or clinician approach. So I think that that's one area that we haven't explored enough. And then I also think that the limitation in this sort of second part of the question, I think, there's a lot happening with AI. I think it's going to be very hard to keep up. There's a lot happening with digital health frameworks and digital health governance by governments, by regulatory bodies. I think a lot of that is very necessary, but I'm not sure that it's not going to be outpaced by the technology itself. And so we have to be very wary and very aware of how we build things, what might happen with that information, what information is absolutely necessary, what information is not necessary in terms of storing or keeping. We're always very mindful of how this information could be used by someone if it's hacked or against someone if it's subpoenaed, because that is not our goal. We want to make sure that whatever we're offering is something that's going to support someone and not end up having someone be penalized for trying to change, for example. So I think that that's where I feel like there's still a bit of Wild West about the idea of digital health interventions, for lack of a better term. It's just kind of an area that we need to be really paying attention to how we govern and support, particularly when you have researchers who aren't necessarily digital health specialists, but also incorporating the consumer and lived experience adds this layer of having to bring in someone else who has the knowledge of the digital health and the tech, and it can be very complex. And so being very aware of that.
Absolutely. Yeah. Very thoughtful answer. Thank you so much, Krista. And actually kind of leads into really nicely another question, which is just can you maybe talk a little bit more about how you see digital health interventions being combined with the kind of face-to-face treatment that workers might already be doing in services?
So I still think that there's something to learn, and perhaps maybe from our mental health colleagues around stepped care. And I think that one of the stepped care approaches that we could potentially use in our sector is in terms of DHIs is really around that waitlist area. So when somebody calls up and has that tremendous disappointment by having no accessibility, being on a wait list. They called because they were ready. They were prepared to change something in that moment. And it's defeating for us as well because we don't want to wait list people. But unfortunately, the way that resources are, that's often the case. And so I wonder about that DHI in that sort of like provided and guided respect. So maybe when someone gets told that they're on a wait list, maybe they could be told at the same time, go to this website, download this link. Here's this app that you can start working with so that you have something to bounce off your clinician the first time you meet them. Or, your first appointment is in 3 weeks, but perhaps if you do this in the meantime, you and your clinician could sit down with the results that you've recorded in whichever resource we're talking about. So I think that there's something there. And then, of course, there's also the question about how much large language models will fill in some of those gaps and whether that's the best alternative in that period. We just don't know that yet.
Absolutely. Very, very good. I've kind of got like a chat document and a Word document open at the same time, so I'm just kind of flicking between them. There's another question here. I think you touched on this briefly, but maybe if you could just reiterate. When people sign up to the app, is it de-identified or do people have to register by name? So maybe if you could
Yeah.
talk a little bit about that process and the confidentiality stuff that's in place as well, potentially.
Yeah, so we only collect de-identified information. Whatever somebody chooses to store on their phone is separate, but we collect de-identified information. We're not able to re-identify you through the app. I can only speak to the NCRED resources. And then also because of the Australian governing framework around digital health interventions, as it were, we also have strict security rules around, for example, all of the data that you do input into the app in terms of questionnaires, for example, being stored in Australia under Australian frameworks for security and data management. So those are really important aspects of our design that I think are something that we have an advantage in Australia around some of the overarching regulatory frames that we can work under. So I think that that's of benefit in terms of the Australian context. And that is as well why we have limited our intake for participation in our studies to Australian residents, people who are in Australia. And that all has to do with that data management and data flow. But certainly I think that that is something that I would be very conscientious of in the context of methamphetamine use intervention, around reading the fine print that we all sort of accept without thinking, or at least maybe different generations don't. But I know I just press accept. And I think with this, in this setting, we have to be thinking a bit closer.
Yes, absolutely. Thank you. Really quickly, there's another question here about the website to access this. I gave the wrong acronym before, my apologies. The website to go to would be nccred.org.au is where we go for that one. And that stands for the National Centre for Clinical Research on Emerging Drugs. So just to correct
And there'll be a QR code with the PDF file that comes in with the slide deck later. So that should all be accessible.
Amazing. Thank you so much for that. Thank you so much for that. Looking at another question. So there's also a lot of thank yous for an excellent presentation, just so you know.
I
But
hope that
another
the sound was
question.
okay. I apologize for the folks who struggle with the sound. Sorry about that.
Thank you. I could hear it pretty well, so I think the message got across, which is good. Is harm reduction information included as part of the S-Check app?
Yes, we do. And we also have link outs to other places that have sort of gold standard, there are expert organizations. We're lucky in Australia with NGOs who are expert in harm reduction services, information, guidance, and support. And so we also have link outs to some of those colleagues as well.
Awesome. Excellent. Someone asking here just about polysubstance use. So many of my clients are polysubstance users. And what thoughts do you have around approaches to moving between different substances in more or less harmful directions, perhaps following engagement?
It's a good question. And I think, I mean, certainly with some of the CBT programs, the same underpinning rationale for the CBT would work in any context, including polysubstance or in a different substance. Certainly what we've tried to do with Impact, the CBT program that we're about to launch, is to make it methamphetamine specific so that people can see themselves in the characters and the examples that are on the screen. So I wouldn't think that that would limit access for someone who has polysubstance use, because they would identify with the methamphetamine use examples. But, you know, perhaps someone who had a primary cannabis use disorder and didn't have any other polysubstance use might not see themselves as much in that imagery and might look for a cannabis specific resource. And so we really were holding that. But I think, you know, as long as we're establishing resources that people can identify with and feel like they can see themselves, and work through those examples in a way that is relevant and resonates, I think that that's probably the primary goal.
Yeah, excellent, excellent. Thank you. Are you able to talk to us and just what I'm wondering, are you able to tell us about with the Wadawanti app, what kind of consultation the app development team went kind of like engaged in order to kind of tailor an app and an approach to First Nations peoples?
Yeah, so that app, there's colleagues, including Rachel Riley, have really published a couple papers on this. So if you look up, I think I've included the QR code, but I'll double check my slides for her papers. But really, they did do quite a lot of consultation with community, in addition to which the intervention itself has people who identify as First Nations as the people and characters and presentations and contexts. So they've made it very culturally sensitive, but also culturally specific. And I don't want to sort of state what they have and haven't done. So I would really recommend going back to that work by Rachel. And that was led by James Ward out of SAMRI. When that project started, James Ward really led that and drove that research. So they've got those published, those approaches.
Excellent. And that's really great to be able to kind of, just see what approach a team took and then that can be built upon.
Exactly. I think it's really important that we do more of promoting the steps to get to a place as well. I think that we don't do that enough broadly in science, in terms of clinical research, as opposed to results of the clinical research. I think that there's a lot to say about the conversations and the discourse and the steps that got us there to make the decisions to research the way that we did.
Yeah, if we can make it possible to replicate, that's the ideal, isn't it? Yeah.
Or learn from people's mistakes, because we often have a lot of mistakes that go into the thinking along the way.
Yes, yeah, absolutely. That mistakes are normal.
Yeah.
Another question, just in terms of clarifying terms, just about kind of the way the term waitlist has been used in the talk today. So my sense is that it's used in kind of two different terms. One is maybe waitlist for a service and one is waitlist for the app, which is part of a research project. If you wouldn't mind kind of just, elaborating on that a little bit would be great.
That's a good point. Thank you. And thanks for asking for the clarification, because I have used it in two different ways. So in the clinical trial setting, Breaking the Ice, Wadawanti, and SCHECK, in their randomized control trials, they used a waitlist control. So instead of giving people access to the app or nothing, what they elected to do, which felt more ethical and more approachable, was to give people access to the app immediately or access to the app after a period on a wait list. So for most of those trials, it was a 28-day period whereby you were randomized. You had a 50-50 chance. Once you signed your consent form, you were randomly allocated to either have immediate access and start using the app and all of its tools in a fully unlocked way immediately, or 28 days later, you got an email or a link or a notification to your phone that said you can now access this app in this way, so that everybody had an equal chance of eventually receiving the intervention, but that we were able to compare those two groups in a time point that said, that suggested that there was a difference or no difference, be that as it may, between the groups who accessed right away or who didn't access. So when you got that email or notification after 28 days, you filled in the questionnaires that were the same questionnaires as people filled in after 28 days of using the app. And then we were able to say, did these two groups differ in any way? So that's what I meant by waitlist controlled. So it was similar to how in a pharmaceutical study, we might use a placebo control. Or in some studies, they use a nil control. So you just get nothing or you get an intervention, and then you compare those two groups. But I think that there was a lot of sort of ethical discourse around making sure that somebody had an access at some point. So that's why that waitlist control was selected for those studies. And then the second point that I made was around, as these DHIs roll out into services or into use, or as they hit the app stores, is there a way to utilize them in a context of a service having an intake, and as part of the intake process, people having to wait for a service due to capacity requirements, resourcing, etc. So if you call a service for intake and the intake coordinator says somebody will get back to you in 2 weeks, and then 2 weeks later you get an intake appointment with a clinician for 2 weeks following that, could these DHIs be used in that 4-week interim period? So that's what I meant by that wait list. So I think hopefully that clarifies.
Definitely. Thank you. Thank you. And just to kind of clarify, if people are, discussing with their clients that they may wish to investigate these apps and use them, am I correct in thinking that because it's still part of a clinical trial that they have a 50-50 chance of still, like they'll get it at least in a month or right away, or is it different now?
So at the moment, because we already did, so for SCHECK, because we already did the randomized controlled trial, for SCHECK, this new study is just a cohort study, so everybody can access the app immediately. So when you go into the SCHECK app on the App Store, you get access to that app as soon as you download it and consent. But then your data is being used in a de-identified way just to monitor your outcomes over time. So just looking more at those secondary analysis that I talked about, for example, if the app use increases, does the methamphetamine use decrease? So those were all secondary analyses that we found some results that were statistically significant, but we'd like to apply that more broadly in a cohort of people, a sample of people who download the app. So that's SCHECK, and IMPACT will work very similarly. When that launches, that web-based application will be a research project whereby people come in, access the resources, and then we look at their depression and anxiety scales, for example, over time to see if, as they use the resources, or if they use the resources more, if there's a group that use more or less of the app, or it's not an app, the website, sorry, whether there is any differences amongst various groups within the cohort who access the service. So both those services are available as research projects for immediate non-randomized allocation.
Right. Yeah. Okay. So yeah, it sounds like people can kind of just get right on it if they want to with those ones.
Yeah, we would love that.
Excellent.
Thank you so much.
Yeah. No worries. I think we're 2 minutes to great question, because we can probably answer this in a minute. Can people participate in both?
Yeah, they absolutely can. And I think that that'll be an interesting outcome of the research will be to see, we'll never be able to link, we'll never know if they participate in both. But as we do, as we get feedback from clinicians, for example, it'll be interesting to see whether people dip in and out of both simultaneously, or whether maybe SCHECK helps to identify that there are some problematic things that I'd like to change, and IMPACT will help me do that. So it's an interesting kind of, like, as I mentioned, it's a continuum, and you might go back and forth between the various needs. So people can absolutely participate in both.
Excellent. Thank you very much, Krista. That was a really, really interesting presentation. I really enjoyed it, and it was really nice to have an opportunity for kind of questions and discussion at the end. So you're definitely welcome back anytime.
Thank
Thank
you. And I
you.
really want to thank everybody who came out. I appreciate you taking the time. I know it's an hour out of a very busy schedule for most of us. So thank you.
Amazing. Thank you. So just to wrap up, yes, thank you again to Krista for presenting today. We hope to see all of you again next Wednesday for that webinar. That one will be presented by Matthew Gullo and is called Tinker Tailor Scientist Practitioner, Personalizing Psychosocial Treatment for Addiction. So thank you again, Krista, and we hope that everyone enjoys the rest of your week. See you later.
Bye.